So I'm going to talk about the management of poor or no blastocyst development. So disclosure, this is my full disclosure. I think during this talk I will have only one conflict of interest. It's because I'm going to talk about sperm selection and I'm a shareholder in a microfluidic company. So what is the definition? We have to define poor blastocyst development. And we have two choices. We could take the patients falling below blastocyst development rates, competency values that have been defined in the Vienna Consensus. Or, and this is my preferred option, we can take the definition from Thomas Ebner in 2015, which is either complete developmental arrest, so no usable blastocyst at day 7, complete developmental delay, so no blastocyst at day 5 of culture, or significantly reduced blastocyst formation, i.e. less than 15% blastocyst per 2PN zygotes. And also, all the patients who only have very poor morphological quality. Clinical context. I think there are two main clinical contexts. Two clinical presentation of poor blastocyst development. There is the expected, in quotes, expected one, which is couples with patient with advanced maternal age, over 38 years old, patient with a previous poor ovarian response, patient with low ovarian reserve, and also partner with severe male infertility, just like non-obstructive azoospermia, and also advanced paternal age. And there is the most troublesome situation. It is the unexpected poor embryo development or no embryo. It is a patient with normal or high ovarian reserve, a young patient, and we cannot find with the standard examination any clear explanation in the male or in the female. Sometimes you have mild semen alteration, but this is not something that we want to focus on. And this patient tends to have recurrent poor embryo quality, irrespective of stimulation type or even culture media. And this is the situation when we have an issue, because we don't have much studies about this population of patients, and we don't know how to explain poor embryo development. So I had to make a choice for this presentation. I found, of course, studies that were looking at this kind of patient, no blastocyst or poor embryo development, but I also choose to present some data and some clinical situation where you have a higher or lower prevalence of good embryo quality, and also some intervention that are not focused on poor embryo development patient, but that could increase, that have been shown to increase oocyte blastocyst quality, oocyte and blastocyst development. So, if we're looking at molecular alteration that can lead to poor embryo development in the female, we have a plethora of studies, of fundamental studies. But we have a recent meta-analysis review about some pathogenic variants of gene that regulates early embryo development. And there are families with this kind of mutation, especially in a complex that is called subcortical maternal complex, a family of genes and proteins that will regulate the division of the oocyte, the first division, but also the early embryo development, and some mutation are associated with early embryo development arrest. But these are really seldom cases. And we have also a lot of papers about ovarian follicular fluid inflammation, oxidative stress effect on spindle, membrane of the oocyte, mitochondria dysfunction, even variants in the MTHFR genes, follicular fluid alteration also that have been linked to poor embryo development. In the male, we know that there are paternal factors that contribute to early embryo development, even seminal plasma components, sperm centrioles, some proteins in the sperm like CAT-SPER, like phospholipase C-zeta, and more recently, it has been shown that the epigenome and the epigenetic information in the spermatozoa can be involved in poor embryo development. And this can happen even when the male patient has normal semen parameter. This was the case, for example, in the study from Denham. So this team have shown that spermatozoa epigenetic abnormalities in normozoospermia males can be linked to poor blastocyst development when they use donor eggs. So it's not because the male has normal semen that the male is not involved in this issue for your patient. Etiologies and potential treatment. We are going to start with lifestyle and habits associated with embryo development and quality. So in the male, it has been shown that smoking negatively impacts KIT score at day 3 in one study from Oak in 2020. But also, smoking and chewing tobacco is negatively associated with day 3, but also day 5 embryo quality. So it's a good idea, even if there are no clear evidence, but it's a good idea to explain to the male patient in that case that they have to quit smoking. In the female, and this is a study from Cochin, active smoking is an independent risk factor for total delayed blastulation. And also, a high folate, which means metal-rich, and antioxidant diet, like the Mediterranean diet, is positively associated with KIT score day 3, especially in overweight women. And lastly, eating and social habits impact cleavage stage embryo quality and likelihood of blastocyst formation in the female. This is a study from Braga. And what they've shown is that there are protective habits, like eating fruits, vegetables, fish, or cereal diet. Again, very Mediterranean diet, metal-rich, omega-3 rich diet. And there are harmful habits, especially for the likelihood of blastocyst formation. Red meat, weight loss diet is negatively associated with the blastocyst, the likelihood of blastocyst formation, alcohol, and also smoking. So we can see that these are clearly the recommendations we give to our patients, our standard patient, but this is something that we have to enforce and focus on when we are dealing with poor embryo development couples. Now, environmental exposures associated with embryo development or quality. In the male, it has been demonstrated that exposure to phthalates is inversely associated with day 5 blastocyst quality. So the higher quartile of phthalate exposure, there is a decrease in day 5 blastocyst quality. And also in a more recent study, D5 embryo quality was significantly and negatively associated with the residence in an industrial locality of the male partners. In the female, I found one study focusing on embryo quality, a study from Carré in 2017. It was demonstrated that there was a negative impact on NO2 and particulate matter 10 on embryo quality, especially for acute exposures during early follicular growth, i.e. 60 or 90 days before oocyte pickup. Now, are there any pre-existing conditions that are associated with embryo development or quality? In the male, I only found some studies on varicocele and varicocele repair. So if you do varicocele repair in an unselected infertile male population, there is no association of varicocele repair with embryo quality. In the other hand, in severe oligoazoteratospermia patients, varicocele repair significantly improves embryo quality and blastocyst rate here. This is a study from Guo in 2016. And when we are talking about a zoospermic patient, the effect on embryo quality is not clear, even though treating the varicocele improves recovery of testicular spermatozoa and also live birth rate, as has been demonstrated earlier. In the female, if you look at the fundamental data, PCOS patient, endometriosis patient, advanced maternal age patient, it has been associated with oxidative stress as well as with ovarian inflammation. And these fundamental data are in favor of poor oocyte or embryo competence in this patient. So if you read the fundamental data, you end up telling yourself, my God, how is it possible that we have embryos? But if you look at large studies of IVF or ICSI patients with endometriosis or PCOS, these studies fail to find any differences in embryo development compared to control patients. However, in endometriosis, if you look on patient, if you focus on patient with poor embryo development, there is at least one study that has shown that complete resection of endometriosis lesions improve blastocyst quality. And this improvement is an improvement that is very tangible because it's done with the KIT score. It's not a quality like blastocyst, like trophectoderm quality A or B. It's the KIT score, so it's very precise and reproductive. Endometrioma. Endometrioma, however, its presence has been associated with a reduced blastulation rate in a study by Cheng in 2023, but also with a reduced number of top-quality blastocysts in a meta-analysis from Gaye Lafuente very recently compared to endometriosis patients without endometrioma. And we know that laser ablation of endometrioma can improve embryo quality without compromising the ovarian reserves in patients being offered ART. Now, PCOS. So it has been described that in PCOS patients with normal BMI, but with insulin resistance, there are significantly less blastocysts usable for freezing. And in PCOS patients with metabolic syndrome, there is also a tendency, not significant, but there is a tendency to obtain less top-quality embryos. And so more recently, it has been shown that when you give insulin sensitizer molecule just like myo-inositol, you can improve embryo quality in PCOS patients. And this is the study from W. Doriak in 2016 that is showing that especially you have a normalization of Sengemi time, early cleavage timing, and also a shortening of the time to blastulation. So again, time-lapse and morphokinetics can give us some insight into what our interventions do maybe better than morphology alone. And more recently, in RCT from Tabatabai in 2022, it has been shown that myo-inositol pre-treatment, so 4 grams a day, 1 month prior to IVF, led to an increase in high quality embryo and a decrease of bad quality embryo compared to control. So now let's talk about BMI per se. Maybe not associated with PCOS. And this is very interesting because the results are very contradictory. So in IVF and ICSI, a BMI over 28 has been associated with significantly higher blastulation rate compared to normal BMI, which is quite the opposite of what we can think about for PCOS patients. So it's not that clear. Vitamin, antioxidant supplementation, CoQ10, ubiquinol. There is one study, one RCT, focusing on young patients with diminished ovarian reserve. It showed that there was significantly less culture failure when 600 milligrams of CoQ10 was given per day 2 months before oocyte pickup, and also significantly more high-quality embryo and cryopreserved embryo. Melatonin, an antioxidant. In PCOS patients, adding melatonin to myo-inositol supplementation improved the percentage of top-quality embryo in the first ICSI cycle in a study from Pacchiarotti. And also, melatonin supplementation improved the number of top-quality embryo in patients with a diminished ovarian reserve. Vitamin D. Vitamin D, we have a descriptive study showing that there is a significantly decreased blastulation rate in low serum vitamin D patients compared to vitamin D replete patients. And this is irrespective of the protocol type. So what about a combination of vitamin and antioxidant. So this is an RCT from WWEC 2020 that's shown that in patients less than 35 years old, first 60 cycle, idiopathic infertility, when you give a combination of vitamin D, melatonin, and myoinositol, you have an increase in the percentage of blastocyst transfer compared to control. But the results are actually so magical that I had trouble believing in it. Vitamin B complex. So we often hear about MTHFR, folate, and everything. What is known is that elevated homocysteine levels in follicular fluid are associated with oocyte and embryo quality in infertile patients, and especially PCOS. But the causes of homocysteine elevation includes MTHFR polymorphism, vitamin B complex deficiencies, as well as unhealthy lifestyle and especially smoking. And we also know that high B12 in blood and follicular fluid correlates with a better embryo quality. But what about giving a supplementation with vitamin B complex? I found one RCT that shown that in PCOS patients, a methyl donor supplementation promoting 1 carbon cycle function and starting 2 months, again, before oocyte pickup, significantly improved blast rate compared to control. And I cannot stop thinking about what about PCOS patients or non-PCOS patients who have MTHFR polymorphism. Will they not be a good population to do the study? Now, control ovarian stimulation individualization. So first, the FSH dose. It has been shown by RCA in 2014 that blast rate is inversely correlated with the recombinant FSH daily dose. However, blastocyst rate has also been found to be equivalent with a high, i.e. Over 3,000 units, or low, i.e. Less than 3,000 units total FSH dose is given, and irrespective of gonadotrophin use. So there is a controversy. This is not clear. Moreover, in this last study from Cosolino, higher HPHMG total dose in young patients actually led to lower aneuploidy rate. So it may be good to stimulate young patients with this kind of molecule. So this data warrants for FSH dose individualization. And also, when you talk about FSH dose, it's a bit complicated. I think we should talk more about ovarian sensitivity index. And it has been shown that the higher the ovarian sensitivity index, the higher the number of high-quality embryo in IVF. So I think we should start sorting the patient with ovarian sensitivity index more than the total dose or daily dose. Now, individualization, of course, the type of gonadotrophin. We've seen that it seems to be irrelevant, even though HPHMG was thought, it's a study from Bosch in 2011, that it could improve ovarian response and embryo quality in patients with low basal androgen or low androgen production under recombinant FSH stimulation, especially in advanced maternal age. Now, a very recent study showing that a biphasic stimulation, i.e. starting with recombinant FSH, and when you introduce the antagonist, at that time you introduce the recombinant LH, is actually better for patients that are over 35-year-old or that have less than 4 oocytes found than starting with recombinant LH and FSH. It's better for embryo quality. You have a significant increase in blastulation rate. Cause individualization, day of trigger progesterone. It is known that top quality blastocyst rate and time to blastulation have been shown to be inversely correlated with progesterone level at trigger, but we don't know why. Is it because of an FSH overdose and recombinant FSH it's too potent, too high response, premature luteinization, or is it because we wait too long, we have post-mature oocyte? So we have strategies, especially for advanced maternal age, to avoid premature luteinization, and especially for advanced maternal age, it has been shown that early retrieval, when the follicle is between 16 and 18 millimeter, may improve embryo quality in advanced maternal age patients. So, but this was a study with a low number of patients. So there are many strategies to avoid premature progesterone elevation, and although there seems to be an impact, it is not clear if avoiding premature progesterone elevation promotes a better embryological outcome. Dual trigger, it is the place where there are the most powerful evidence that dual trigger increase your blastocyst rate, whether it's in diminished ovarian reserve patient, normal ovarian reserve patient, but also patient with a previous cycle with no embryo. So, COS adjuvant therapy, it is known, I don't have much time, so I will go really fast. So it is known that growth hormone adjuvant therapy seems to improve embryo quality, especially when patients have a poor embryo quality on a previous cycle. DHEA also, supplementation seems to have an impact in a recent meta-analysis in poor ovarian reserve patients, and also GCSF in a very recent RCT. So I will skip on the lab intervention. We don't do arm in the lab. The only thing we can do is not do arm, but we can try to not do arm by, for example, using the right fertilization technique. So some very light brush, short co-incubation of gametes seems to provide better embryo quality. Also doing your ICSI in a physiological medium, not a medium with hippies. Piezo ICSI, when you have poor embryo development, seems to also give you a better result in terms of embryo development. Calcium ionophore, it's a controversy. We don't know yet if it's useful. Abstinence time, shorter abstinence time seems to be useful for embryo quality. Testicular spermatozoa, and you've already talked about it, seems to be useful when you have previous ICSI failure. And the semen preparation techniques without centrifugation, just like PIXI, horizontal swim-up, rheotaxis, have also shown an improvement in embryo quality. Selection technique, IMSI, very important, very useful when you have a previous total embryo developmental arrest, and PIXI, but only for high SDF patients. Modification of culture media, positive effect of melatonin, of cytokines, and of peptide also. So we have new fertilization media that may work better. Take-home messages. So we have to inform our patient really fast. We have to do crisis counseling because they don't like it when they have poor embryo quality. And we have to have a good plan for them, decision making. And we have to be honest and to present the cost and the benefit. Treatment principle, correct, of course, the factors. Individualize, it's the keyword, individualize. Multidisciplinary decisions, because we are talking about multiple potential causes, and individualization. If they are usable embryo, tell them that it's okay to use bad quality embryo, even though pregnancy rates are lower, the neonatal outcomes are strictly the same. And if there are no usable embryo, of course, you can promote donation or adoption and experimental technique, of course, in a research and clinical trial. Thank you very much.